My name is Bradley Kushner, and I'm a general surgery resident at the Washington University in St. Louis. I would like to thank SAGES for the opportunity to present our work entitled Robotic Approach Results in Improved Perioperative Outcomes for Paraesophageal Hernia Repair. The authors of this presentation have the following disclosures. The laparoscopic approach for paraesophageal hernia repair has been employed for nearly 3 decades. From 2002 to 2012, there has been a rapid increase in its utilization, and the proportion of laparoscopic paraesophageal hernia repairs have increased from nearly 10% to 80%. The laparoscopic approach has quickly become the standard of care because of its associated decreased postoperative morbidity, shorter hospital length of stay, and decreased hiatal hernia recurrence rate as compared to the open approach. Despite its many advances, this technique still suffers from several key persistent challenges. Recurrence rates are unacceptably high and have been reported in as much as 57% of patients in high-volume centers. Esophageal lengthening procedures such as the Colles gastroplasty or the wedge fundectomy are still frequently required, often with resultant dysphagia and problems with long-term reflux control. Lastly, revisional paraesophageal hernia repairs are one of the most technically challenging and demanding foregut surgeries and have been associated with increased operating room times and complication rates. The robotic-assisted paraesophageal hernia repair is a promising alternative to the traditional laparoscopic approach. Robotic technology offers increased degrees of freedom, longer instrumentation, a stable camera controlled by the surgeon, and a seated operative console. Following its FDA approval, robotic surgery has seen a rapid growth. In 2000, there were only 18 Da Vinci robotic surgery consoles worldwide, and in 2019, that number has increased to over 5,000. Early reports on patient outcomes with robotic paraesophageal hernia repair suggest that the procedure is both safe and reliable, as well as feasible. Currently, there is a paucity of large database studies that compare the perioperative clinical outcomes between the two. The goal of the study was to use the largest robotic paraesophageal hernia database to date to compare the perioperative clinical outcomes of a robotic paraesophageal hernia repair to the laparoscopic approach. A prospective IRB-approved database was maintained for all robotic paraesophageal hernia repairs performed at a tertiary academic medical center from January 2009 to December 2019. All robotic surgeries were performed by a single expert robotic and laparoscopic surgeon utilizing either the Da Vinci SI or the Da Vinci XI surgical system. A retrospective review of laparoscopic paraesophageal hernia repairs over the same time period was used as a comparison group. Over 90% of laparoscopic cases were performed by 2 minimally invasive surgeons that each have over 20 years of experience and have each performed greater than 1,000 laparoscopic foregut cases. Patients in the study were at least 18 years old and had symptomatic type 2, 3, and 4 paraesophageal hernias. In robotic and laparoscopic cases, both Nissen and Toupet fundoplications were performed, and the choice of fundoplication was based on the patient's baseline esophageal motility as determined by routine preoperative high-resolution manometry. A total of 1,854 patients underwent paraesophageal hernia repair during the study time period. Patient gender, paraesophageal hernia type, incidence of obesity, and the urgency of the operation were similar between the two cohorts. Patients with a previous hiatal hernia repair made up a significantly higher proportion of robotic cases than in the laparoscopic group, and patients were slightly older in the robotic group as well. There are several key outcome differences between the two groups. The robotic cohort had a significantly reduced number of esophageal lengthening procedures performed, had fewer intraoperative injuries, and had reduced length of stays by over 1 day. Additionally, the robotic cohort had no conversions to open as compared to 72 patients in the laparoscopic cohort. Finally, the robotic cohort was associated with a $90 increase in intraoperative equipment costs. The use of the robot facilitates greater access to the more superior portions of the mediastinum, owing to the added length of robotic instrumentation, its ability to retract and expose the hiatus, and the added dexterity of the wrists at the distal end of the robotic instruments. These features enhance the mediastinal, esophageal, and circumferential gastroesophageal junction dissection, and likely contributed to the fact that only 1 patient in the robotic cohort, as compared to 113 in the laparoscopic group, required an additional lengthening procedure. While the robotic group was associated with slightly higher intraoperative equipment costs, it is unclear whether long-term cost savings might be achieved with the robot's associated decreased length of stay and decreased open conversion rate. This study was one of the largest robotic foregut case series presented to date and demonstrates that not only is the robotic approach to paraesophageal hernia repair safe and feasible, but it also has several key potential advantages in perioperative patient outcomes when compared to the standard laparoscopic approach. Further large prospective cohort or randomized control trials are needed to compare both the short and long-term outcomes of the robotic and paraesophageal hernia repair, and itemized intraoperative, perioperative, and long-term cost comparisons between the two approaches are needed. I would like to acknowledge and thank Dr. Awad and the entire minimally invasive surgery team at the Washington University in St. Louis for their tireless efforts on this project. My email address is listed below, and please feel free to reach out with any questions or discussion topics.